This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2013, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Exposure Control Practices Associated with Administration of Aerosolized Medications, Results of the NIOSH Health and Safety Practices Survey of Healthcare Workers. Upon the completion of this AARC webcast, participants will be able to identify the NIOSH survey methods and implementation, discuss the extent of use of exposure control practices by healthcare personnel who administer aerosolized medications, and identify the barriers to the use of exposure control practices by healthcare personnel who administer aerosolized medications. I am pleased to welcome Mr. Jim Boiano. Mr. Boiano is a Senior Industrial Hygienist in the Surveillance Branch, Division of Surveillance, Hazard Evaluations, and Field Studies, NIOSH in Cincinnati, Ohio, and also serves as the Assistant Program Coordinator of the NORA Healthcare and Social Assistance Sector. He has over 30 years of experience as an occupational health and safety researcher, including 10 years as an industrial hygiene consultant. He received an MS in Environmental Health from the University of Cincinnati and is certified in the Comprehensive Practice of Industrial Hygiene by the American Board of Industrial Hygiene. Jim's research has recently focused on developing and implementing worker and management-based surveys to learn more about health and safety practices in the healthcare industry. Currently, he is managing a survey evaluating the use of exposure control plans for bloodborne pathogens in private dental practices. In 2011, he completed a survey of healthcare workers related to the use of hazardous chemicals, and this survey is a topic of his presentation today. Neither Jim nor I have conflicts of interest related to this presentation. Brand names of products may be mentioned only as examples of technology. Jim, welcome to the program.
Yeah, thank you, Shauna, for inviting me to speak with AARC members today. As you indicated, the title of my presentation is Exposure Control Practices Associated with Administration of Aerosolized Medications. And this is one part of a larger study that we conducted of healthcare workers. Before I start, I'd like to acknowledge Andrea Steggy and Marie Sweeney, who have been involved with the survey project from its inception. Also, I need to mention that the findings and conclusions in this presentation are those of the authors and do not necessarily reflect the views of NIOSH. They have not been formally disseminated by NIOSH and should not be construed to represent an agency determination or policy. So what I'm going to be presenting today follows this outline. So I'm going to give you a little bit of background on NIOSH, the purpose of the survey instrument that we used, survey implementation methods, the number of respondents that completed the survey by module, selected findings for aerosolized medications, which was one of the survey modules, the strengths and limitations of the survey, and information resources. So what is NIOSH? NIOSH is a federal agency responsible for conducting research and making recommendations for the prevention of work-related injury and illness. NIOSH is part of the Centers for Disease Control and Prevention and we are in the Department of Health and Human Services. NIOSH and OSHA are distinct separate agencies. OSHA is in the Department of Labor, and OSHA creates and enforces workplace health and safety regulations. So to give you a little bit of background on the survey, its inception, the survey addresses goals of the National Healthcare and Social Assistance Sector agenda. And following a competitive external review process, it was funded by the NORA program. And NORA, also known as the National Occupational Research Agenda, is a NIOSH-sponsored partnership effort to define and conduct high-priority research addressing occupational safety and health issues. And in this slide, I provided links to both the NORA program so you can learn a little bit more about the NORA program that NIOSH has, as well as the link to the sector agenda developed by the Healthcare and Social Assistance Sector, and this by the Sector Council. And this Sector Council is composed of both internal NIOSH researchers as well as external participants representing labor, academia, the private sector, and others. So the purpose of the survey is to describe health and safety practices associated with selected classes of chemical agents that are widely used by healthcare workers. And also, we wanted to characterize the extent of use of exposure controls, as well as characterize barriers to using personal protective equipment, such as respirators and protective clothing, for each of the chemical agents that were targeted in our survey. So, to give you a little bit of background on the study population, basically the study population was comprised of members of 21 professional practice organizations representing various healthcare occupations who routinely use or come in contact with chemical agents as part of their job. And the participating organizations, as well as the members, were interested in improving health and safety conditions in the workplace. And one of those 21 professional practice organizations was ARC. So the survey instrument that we used was developed internally, and it was also drafts of the survey instrument were shared with the participating professional organizations to have them look at the content and provide us with comments in order to improve the survey instrument. The survey instrument itself included a screening module and 7 hazard modules, as well as a core module. The hazard modules addressed aerosolized medications, anti-neoplastic drugs, chemical stimulants, high-level disinfectants, surgical smoke, and anesthetic gases. The hazard module on aerosolized medications consisted of 3 subsections, one for antibiotics, and we specifically looked at 3 antibiotics, amikacin, colistin, and tobramycin. I hope I'm pronouncing those correctly. And then we had other subsections addressing pentamidine and ribavirin. The hazard module on high-level disinfectants addressed glutaraldehyde, orthothialdehyde, peracetic acid, and hydrogen peroxide. And the hazard module on chemical stimulants addressed ethylene oxide and hydrogen peroxide gas plasma. The module for anesthetic gases addressed nitrous oxide, and a few halogenated anesthetic gases, including desflurane, enflurane, halothane, and sevoflurane. We had a module addressing surgical smoke, which consisted of two subsections, one for smoke generated by lasers and the other for smoke generated by electrosurgical devices. And then the core module addressed a number of topics which will be detailed later. So the chemical hazard modules addressed these following topics. Each of the hazard modules addressed these topics. So they addressed hazard-specific training, the frequency of training, awareness of safe handling guidance, or employer standard procedures for the safe handling of the chemicals, the frequency and duration of use of the chemical agents, the extent of use of exposure controls, and this includes administrative controls and also personal protective equipment, whether there was any exposure monitoring conducted for the chemical agent, and that kind of depends on whether or not exposure monitoring methods exist, and then whether or not a medical surveillance was conducted, medical monitoring or medical surveillance of healthcare workers by their employer, and that's sometimes chemical dependent as well. Now the core module addressed a number of topic areas, including that was the module that we collected information on demographics. We also collected information on the industry, occupation, and employer characteristics. And then there was several questions that addressed various cross-cutting health and safety issues, including workplace stress and violence, physical job demands, whether there's any lifting on the job, whether it's lifting of equipment or lifting of patients, work organization issues such as length of work shift, whether there was any mandatory overtime, whether there was, whether they had a standard work week, shift work, and things like that. Hand hygiene practices, the frequency of washing hands, that's what that primarily addressed. And then we also collected information on work-related injury, illness, or exposure in the past year, and also seasonal influenza practices, whether a healthcare worker was wearing a respirator while attending to a patient that had flu or flu-like symptoms. And then also we had a number of questions that dealt with health and safety perceptions. So the survey, the web survey, this survey was exclusively conducted as a web survey, and it was programmed to initially present a screening module, followed by a hazard module, then a core module, and a second hazard module if indicated. The screening module determined participation eligibility and asked whether or not the respondent administered, used, or was in close proximity to one or more of the targeted chemicals within the past 7 calendar days, or in the case of pentamidine, whether that was within the past 30 calendar days. A 7-day period was used for all targeted chemicals except pentamidine to ensure accurate recall. The past 30-day period for pentamidine questions was suggested during cognitive interviews because some treatments are administered no more than once every 30 days, and we wanted to be able to capture that. There were multiple screener questions, each targeted to a chemical hazard. They were programmed so that the first question presented to respondents corresponded to the most relevant hazard module for the respondent's professional organization. So, for example, the first screening question presented to a respondent invited by AARC was for aerosolized medications. The survey was programmed to present only the top 2 chemical modules, even when the respondent indicated that in the screening module that they were exposed to more than 2 of the chemical hazards. The top two hazard modules were based on ranking of exposure potential by the respondent in the screening module. The respondent could complete no more than 2 hazard modules in the core module. So at most, they would complete a screening module, hazard module, a core module, and then a second hazard module. This table shows the occupations that were associated with each of the hazard modules. In most cases, more than one occupation was targeted to a particular chemical hazard. The only exception was for aerosolized medications, where respiratory therapists represented the only occupation specifically targeted to this hazard module. The survey was made available to members only as a web-based survey. Because survey recruitment for individual respondents was by email, the sampling frame represented a list of member email addresses maintained by each of the participating professional practice organizations. Each organization was responsible for sending survey invitation and reminder emails to invited members using a template prepared by NIOSH. The emails included a link to the survey, which was hosted on a secure website maintained by our contractor. Participation was voluntary and anonymous. The email list was not shared by our contractor with us, with NIOSH. The survey was open for 8 weeks, starting at the end of January in 2011 and running through the end of March. Completion time for the survey was about 30 minutes if the respondent completed a hazard module and the core module, and if they decided to continue and complete a second hazard module, that survey would have taken about 40 minutes to complete. So this was a rather long survey. So those of you that may have that participated in the survey may recognize that this is the home page for our survey. The survey was approved by the White House Office of Management and Budget, and approval numbers appear in the right-hand corner. And for any federally sponsored data collection effort that involves more than 9 individuals, you need to a federal agency needs to seek OMB approval, and this approval typically takes anywhere from 8 months to a year. So those are some of the challenges that a researcher in the government faces when developing a survey instrument. When you continue on with the subsequent screenshots, I don't have those shown here, but for an individual participating, if they're invited by AARC to participate in the survey, they were provided with a four-letter organization key. And so when they logged into the survey, they would provide that 4-digit key, and that would allow NIOSH to group the data by organization, because one of the products of our survey was to provide each organization with a report for their members who completed the survey. And then also this survey had the capabilities of someone who would enter the survey and then for whatever reason wouldn't be able to complete the survey. we provided them with a resume survey code so they could re-enter the survey at the point they left off in order to complete it. The survey also had a number of skip patterns embedded within the survey, and that was done to allow the respondents to skip questions that weren't really relevant to them. So the total number of respondents by survey module is presented in this table. The surgical smoke hazard module had nearly 4,800 respondents, the most of any of the hazard modules, while the chemical stimulants module had the fewest at around 430. The hazard module on aerosolized medication had almost 500 respondents. And overall, there were over 12,000 unique respondents and nearly 11,000, or 90% of the respondents, that completed the core module. So that this has implications, because for those respondents who just completed the first hazard module and then did not proceed on to the core module, well, we don't have demographic information for those individuals. And I'll get into that a little bit later. So this table presents the 2 hazard modules that were completed by AARC members that was above our reporting criteria of 50 respondents. Slightly over 600 AARC members completed the high-level disinfectants module, representing about 13% of all respondents of that module. Nearly 400 AARC members completed the aerosolized medications module. However, they represented nearly 80% of all respondents of that module. For this reason, and the fact that administration of aerosolized medications was most relevant to AARC and its members, the rest of my presentation will focus on results from this module. Let me just go back to that previous slide because I have additional information. AARC members, they did not complete just the hazard modules that they completed were more than just for aerosolized medications and high-level disinfectants. But there was no more than 20 AARC members that completed any of the other hazard modules. And then for the various combinations, the most of the AARC members completed the hazard module on high-level disinfectants in the core module, and that numbered 360. And AARC members with the next highest completion numbers was for aerosolized medications in the core module. And there were 157 respondents who completed 2 hazard modules, the one on aerosolized medications and high-level disinfectants in the core module. And there was a few who just completed the one hazard module. There were 72 respondents who completed the hazard module on high-level disinfectants and did not move on to completing the core module, and there was 36 respondents who completed the hazard module on aerosolized medications and didn't move forward to complete the core module. So as mentioned earlier, the aerosolized medications module addressed 3 different antibiotics, pentamidine and ribavirin. These drugs are primarily, excuse me, I think I'm on the wrong side. I was moving the wrong way and I apologize. So as mentioned earlier, the aerosolized medications module addressed 3 different antibiotics, pentamidine and ribavirin. These drugs are primarily used to treat various bacterial and viral infections. They were studied primarily because of their irritant and hazardous drug properties, and because studies have shown that respiratory therapists are at a high risk of developing occupational asthma. Primary health effects of occupational exposure to the aerosolized medications included in the study are shown in this table. Most of them cause respiratory and eye irritation and asthma or asthma-like symptoms. Pentamidine and ribavirin are classified as hazardous drugs by NIOSH and OSHA. They possess one or more of the following 6 characteristics: carcinogenicity, teratogenicity, or other developmental toxicology, reproductive toxicity, organ toxicity at low doses, genotoxicity, and structure and toxicity that mimics existing hazardous chemotherapy drugs. Healthcare workers administering these medications are also potentially exposed to viral and bacterial infections of patients they are treating. This slide presents selected demographic and descriptive characteristics of respondents of the aerosolized medications module who also completed the core module. 8 of every 10 respondents of the aerosolized medications module were respiratory therapists, nurses, and then nurses represented the next highest occupation who completed that module. Nearly 7 of every 10 respondents were female, 9 of 10 were white, 8 of 10 were over 40 years of age, 8 of 10 had over 10 years of experience in their occupation, nearly 8 of 10 had greater than 6 years with their current employer, 9 of 10 worked in hospitals, and nearly 6 of every 10 worked for a large employer with more than 1,000 workers. This table presents the number of respondents who completed the aerosolized medications module by type of aerosolized medication. The questions addressing aerosolized antibiotics was completed by the most respondents, followed by pentamidine, and to a much lesser extent, ribavirin. These figures include all respondents, not just those from AARC. And one of the things that we learned from the data that you see in this table is that it appears that ribavirin was not used very much, and it could have been associated with the fact that the flu season at the time we administered this survey instrument in 2011 wasn't very significant. I should not say it wasn't the flu season. It was like, I think it deals with respiratory syncytial virus. That wasn't as prevalent as it had been in previous years. And I think there's also been a move away from ribavirin to treat RSV. So this is probably some of the reasons we're seeing that the ribavirin, the number of respondents for ribavirin is relatively low compared to pentamidine and the 3 antibiotics that we included in the survey. So the percent of respondents completing the core module represents those with demographic information. So, for example, 89% of those respondents who completed the submodule or the section on antibiotics had demographic information, and pentamidine was 87% and ribavirin it was 80%. This table presents the frequency and duration of administration reported by a majority of respondents for each medication. Frequency is represented by the number of times the medication was administered over the past 7 or 30 calendar days, depending on the medication. The duration of administration is represented by the number of minutes the healthcare worker was with the patient during a single administration over the past 7 or 30 calendar days where there was a potential for exposure. And by that I mean that the exposure that we were tracking was either during drug preparation, delivery, and it also included cleanup time. Response options were categorical in nature. Aerosolized antibiotics were administered most frequently 2 to 3 times over the past 7 calendar days, and ribavirin was administered at least 1 time over the same time period. Respondents administering pentamidine spent most of the time with patients, typically over 24 minutes, and that was the highest categorical response category that we had in the survey. When adjusting for the differences in reporting period, respondents administering antibiotics had the longest potential exposure duration, while those administering ribavirin had the shortest. Now, before presenting results on the extent of use of exposure controls during administration of aerosolized medications, I wanted to share with you this figure. It presents the hierarchy of hazard controls, an approach used by occupational safety and health professionals to minimize or eliminate exposure to hazards. The most effective method is at the top and the least effective at the bottom. Elimination or substitution of the hazard are most preferred but oftentimes difficult to implement, especially when dealing with medications. Engineering controls isolate workers from the hazard. A ventilated aerosol delivery booth is an example. Administrative controls are changes to the way people work. Training or procedural changes are examples. Personal protective equipment, or PPE, requires worker to wear something. Examples include protective gowns, gloves, eye protection, foot protection, and respirators. When respondents were asked about the last time they had received training on safe handling procedures, nearly half of the respondents who administered antibiotics, a quarter of respondents who administered pentamidine, and 1 of every 6 respondents who administered ribavirin reported that they never received training. So in this bar chart, each bar has a total of 100%, and the response categories are at the right. So they were asked a question, and the responses are: I never received training. The training, I received training, but it was more than 12 months ago, and I received training, but it was within the past 12 months. For the respondents who received training, a majority of those who administered aerosolized antibiotics and pentamidine reported that the training was more than 12 months ago. And by comparison, a majority of those who administered ribavirin reported that the training was within the past 12 months. And according to OSHA guidelines for controlling occupational exposure to hazardous drugs, of which pentamidine and ribavirin are included in that list, the employer should provide training at the time of initial employee assignment and then annually thereafter. Now, when respondents were asked whether their employer has standard procedures for administering aerosolized medications, 3/4 of the respondents who administered aerosolized antibiotics said no or did not know. By comparison, about 2 of every 10 respondents administering ribavirin or pentamidine said no or didn't know. So it appears here that the hazardous drugs, pentamidine and ribavirin, there's greater adherence to established guidelines relative to awareness of employer procedures for safe administration of these medications. This table shows the percent of respondents who reported using specific types of engineering controls during administration of aerosolized medications. These engineering controls were included in the survey based on a literature review, site visits by NIOSH, including myself, and input from practitioners. Some of the engineering controls were medication specific, while others were applicable to more than one medication. The engineering control used by the highest percentage of respondents was a handheld delivery system with expiratory filter for pentamidine administration, with 95% of respondents using this type of device. The engineering control used by the lowest percentage of respondents was a negative pressure room for administering antibiotics, with 20% of respondents administering in a room that was under negative pressure with respect to adjacent areas. No information was collected regarding impediments to using engineering controls. This table presents the percent of respondents who reported always using PPE over the past 7 or 30 calendar days while administering aerosolized medications by type of PPE. The PPE included water-resistant gown or outer garment, protective gloves, eye or face protection, and respirators. Overall, each type of personal protective equipment was used by a greater percentage of respondents who administered ribavirin, and least for antibiotics for eye and face protection and respirators. Extent of use of gloves and gowns were similar for respondents who administered pentamidine and antibiotics at about 80% and 30% respectively. Use of respirators and surgical masks is shown in this figure. Nearly 80% of respondents who administered ribavirin wore respirators compared to 54% for pentamidine and 25% for antibiotics. A greater percentage of respondents administering aerosolized antibiotics wore surgical masks over respirators. Also, in the case of aerosolized antibiotics, respondents reported using both respirators and surgical masks, and explain why percentages add up to more than 100%. Higher respirator use among respondents who administer ribavirin and pentamidine suggests that employers may have more rigorous respirator use requirements for hazardous drugs. It should be noted that surgical masks do not provide respiratory protection and should only be used for infection control purposes, basically to protect the patient from a healthcare worker who may be infected. For respondents who reported that they did not always use PPE while administering aerosolized medications, we asked them to select from a list of reasons for not wearing each type of PPE for each type of aerosolized medication. The top reason for disuse, which was reported for all types of PPE across all medications, was not part of our protocol. The second most reported reason was minimal exposure, and the third most reported reason was not provided or readily available. With respect to ribavirin and pentamidine, again, they're both classified as hazardous drugs. Current safe handling guidelines recommend use of protective gloves and gowns and the use of eye and face protection and respirators whenever there is a possibility of eye contact or inhalation. With respect to antibiotics, prudence dictates that similar precautions be taken to keep exposures as low as practical. The practice of taking home clothing that may be contaminated with drugs may pose an exposure risk to family members and others and extend exposure to the healthcare worker. This figure presents frequency distributions for responses to the question, have you ever taken home clothing that has come in contact with aerosolized medications? 6 of every 10 respondents who administered aerosolized antibiotics and 4 of every 10 respondents who administered pentamidine or ribavirin reported that they had taken home potentially contaminated clothing. So in terms of the survey, we have both strengths and limitations. This slide presents the survey limitations. Now, because the survey population was primarily limited to professional practice organizations and those members with email and internet access, the survey findings are not generalizable to all healthcare workers who administer aerosolized medications included in this survey. The information collected is self-reported, and there was no field or other validation conducted to verify accuracy of responses. Last, the demographic information was not available for those respondents who did not complete the core module. In terms of survey strengths, it is the largest cross-sectional survey of healthcare workers addressing health and safety practices associated with the use of hazardous chemicals. And despite the limitations, survey findings can be used for assessing knowledge gaps and promotion of health and safety interventions. So, summary and conclusions. Based on the survey data, the following summary statements and conclusions have been developed. Worker training and awareness of employee standard procedures are lacking for some respondents, especially those who administer aerosolized antibiotics, and suggest that employers are not aware of the hazards of these medications, placing workers at risk. Use of engineering controls during administration of aerosolized medications is not universal. Absence of information on reasons for disuse preclude full interpretation of these findings and is recommended for future studies. Use of exposure controls is more prevalent among respondents who administered hazardous drugs, pentamidine and ribavirin, as compared to aerosolized antibiotics. This may be due to the greater awareness of safe handling guidelines for hazardous drugs. Employers and healthcare workers may perceive that aerosolized antibiotics are not hazardous because they are not currently classified as hazardous drugs. Respiratory therapists and other healthcare workers administer many other medications as aerosols to patients which not have been studied from an occupational exposure perspective. Prudence dictates that similar precautions be taken to keep exposures as low as practicable. Now, the next several slides, well, actually my presentation has ended, and what I want to do is provide you in the next several slides with links to information on hazardous drugs, journal articles focusing on asthma and respiratory therapists, and information on how to request technical assistance from NIOSH if you are concerned about hazards in your workplace. So you can look at these slides on your own. I'll quickly go through them. So this particular slide provides information that NIOSH has on our topic page on hazardous drugs. It provides the, it provides a link to the OSHA technical manual on controlling occupational exposure to hazardous drugs, and also a link to the Washington State Department of Labor and Industries topic page on hazardous drugs. And here I provided selected journal articles which address occupational asthma and respiratory therapists. And then also, you know, if you have any concerns about the use of aerosolized medications in your place of work, one way to see whether or not they represent an exposure hazard is to contact your employer and see whether or not they can do an internal evaluation, or there's other resources that you can find. And one of those is that NIOSH provides a no fee for service health hazard evaluation. So if you're concerned about potential exposures in your workplace, you can submit a request for a health hazard evaluation, and that request would need to come from at least 3 workers, a representative of a labor representative at the place of employment, or by the employer themselves. And a link to this information is provided here. And also OSHA provides free consultation service as well. So this pretty much concludes my presentation. I am open to take questions at this time. I'll leave you with my contact information. Feel free to call me directly if you have any questions beyond the questions that are asked today. If we don't have enough time to address all of the questions, you know, there's my phone number and email contact if you need to contact me. So at this point in time, I am available to take questions.
Thank you very much, Jim. That was fantastic. For those of you in the audience, the slide that we had a couple of slides ago with the selected resources with respiratory therapy related articles, I posted those in the chat box so that if you wanted to grab that reference, and I apologize for the reference on the asthma risk and occupation as respiratory therapist. Evidently, if you put a 3 in between parentheses, it turns to a basketball. So that's the third issue of that particular publication. So, Jim, thank you very much. This has been a great session, and like you said, the focus of your survey was on the antibiotics, the pentamidine, the antivirals, which obviously our respiratory therapists do deliver, but not all of our respiratory therapists are in areas where they deliver those specific medications. Can the information that you found in this survey be translated to other medications such as albuterol or Atrovent, things that aren't antimicrobial in nature, but still are aerosolized by respiratory therapists?
Well, yeah, I think you know, the engineering controls that are available for pentamidine, ribavirin, for in general for administration of aerosolized medications can apply to delivery of other aerosolized medications. You know, I would say that, you know, if you can smell the medication, there's a good likelihood that you're being exposed to the medication. And you know, given that respiratory therapists, you know, administer various medications in a high number during the course of their normal workday, you know, I think that, you know, whatever they can do to minimize exposure would benefit them, especially considering that, you know, there's information out there that shows that respiratory therapists are at an increased risk of developing occupational asthma. Thank
you very much, and I know that that's a big concern for a lot of us in the field, and providing nebulized therapy to our patients, usually without masks. As I slip backwards in the chat box here, there was a comment about this person was happy that you pointed out the true use of surgical masks. When exposure is possible, would you recommend N95 or HEPA masks?
Well, you know, well, first of all, surgical masks are not considered respirators, and because they do not provide adequate seal, and they are not, they're more designed to protect the patient from, you know, any type of infection that would be carried by the healthcare worker. So if the healthcare worker has a cold, well, then that would prevent, the transmission to the patient. In terms of respiratory protection, N95s, are probably the N95s and PAPRs, so the powered air purifying respirators, are fairly commonly used in healthcare settings to protect the healthcare worker from exposure to, chemical agents. So those are the two most commonly used respirators in healthcare, and the decision would primarily rely with the employer in terms of which particular respirator to use. They both are, the PAPR probably has a higher efficiency, and it provides greater protection than the N95 respirator.
Thank you very much. I know that that's a big issue within our facilities and trying to maintain the health of our practitioners. When we're delivering these medications, one of the comments is that this person's managers wait until the CDC recommends anything before they make a change in policy. When delivering aerosols through various devices, when we have an influenza outbreak, do we think that increases the harm to the respiratory therapist, or do you have any information on that at all?
So is your question dealing with the potential for exposure to influenza, or to the medications that are used to treat influenza?
I think the question involves both. Are we at a greater risk during that influenza outbreak with the delivery of aerosols?
Possibly. I mean, influenza, when there's an increase, like if this fall season, if we have a high, if the flu rates are high, the healthcare workers are at risk, and NIOSH is currently doing studies looking at the efficacy of different types of respirators to protect the healthcare worker. Certainly, there's a greater risk to the respiratory therapist during flu season, and if that, it just depends on whether there's other types of infectious agents that are also on the rise, which would necessitate the use of medications to treat the patient. So it seems like that during flu season, if there's an increased, if the flu season is particularly bad this fall, I would see that the healthcare workers at greater risk, and if they're delivering more medications, certainly they're at greater risk of exposure to those various medications.
Thank you. One more question. Do you know of any links to the development? We talked earlier about the higher likelihood of practitioners to develop asthma symptoms due to occupational exposure. Are there any links to any other illnesses, such as immunosuppressant illnesses? I'm not aware of any. That doesn't mean that they don't exist. In hindsight, I probably should have done a literature search to look at other types of health outcomes associated with respiratory therapists and the medications that they administer. The one, health outcome that was, most prevalent was occupational asthma and asthma-like symptoms. So I can't really answer that at this time. That's fantastic. You've given us a great deal of fantastic information, Jim, and we do thank you for joining us. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation.